of stimulating IgE, for example, to a classic ovalbumin here. And this is measuring the IgE production. And it was interesting that once we knocked out the stimulus here, it didn't happen anymore. In other words, this is stimulating with alternaria. This is without the alternaria over here. And you can see, without alternaria, the mouse was unable to make IgE to other triggers. So that suddenly suggested, and not only the IgE, but also the crucial cytokine for IgE production, the IL-13, was there. In other words, the development of an IgE-mediated allergy was not occurring without the fungus as a trigger, no matter what the allergen was. So you can see that here, that actually a certain B cell was making the ovalbumin to become allergic and reacting with an IgE-mediated allergy, but without the stimulus, the co-stimulus of the fungus, the ovalbumin by itself didn't do anything. So this is knocking out the B cells, and you can see the alternaria as a stimulus doesn't work anymore. Here, it was necessary to actually start making IgE to other triggers. Not only IgE, but also IgE was being made in response to it. So the entire production of the immune globulins there was dependent on the presence of the fungus, not depending on the presence of the actual allergen, which was fascinating in that regard. You can see here, without the fungus being present, there was no production of IgE or IgG in response to ovalbumin stimulus. And again, just to initiate that, here is the ovalbumin by itself, here is the alternaria by itself. It started to make IgE even with the ovalbumin, but then when you started to combine all the allergens, which didn't do anything else, only in combination with alternaria, you started to create a huge amount of IgE production. So I can only emphasize again that this is not just the effector cell, but the pathway we're going down was fascinating. This, for example, is looking at eosinophil degranulation, what stimulates the degranulation of eosinophils. And I want to emphasize that there's only one or actually two triggers which have ever stimulated eosinophils to release MBP. It's very difficult to do. And it was actually two different fungi here in this equation. So this is eosinophil degranulation, and we can actually stop this degranulation now by applying certain antibodies. This is measuring eosinophil release of the toxic protein here. This is without the trigger. And again, the trigger was fungus called alternaria. This is a control antibody. Nothing happens here, but this is an antibody to the CD11B receptor, the complement receptor, and we can now block the degranulation of the eosinophils. But without the trigger, we obviously would not have anything. So I'm just trying to emphasize that the fungus has become a very exciting subject for us and actually starts to take us down a pathway where we can go back to the origin of disease. So in summary, alternaria was actually a common trigger in the patients as well as in the mice there. And the epithelial cells are actually producing the IL-33 in response to the alternaria. The fascinating portion is that about a 30% more potent IL-33 is released when the fungus comes into the game. So you can see also that the innate lymphocytes are reacting to the fungus with the production of the crucial cytokines. The B cells start to produce IgE. Without that, we couldn't get the mouse to react to any other trigger. And again, the eosinophils are actually degranulating in response. This is all done by the same trigger. We're getting very, very excited about because we see a concerted immune response where the epithelial cells, the innate immune system, the acquired Th2 cells, the B cells, and the eosinophils all start to react to the same thing. And alternaria-induced not only the inflammation, but for us became a discovery platform. What I'm trying to emphasize here, that this is something, and I showed you this data before, which actually is reducing not only the inflammation and building the rationale for the use of nasal steroids here, but this is also reducing our surgery significantly when we do that, and it does happen in patients whether they have polyps or not. So the operating time was significantly shortened as well. I want to stop here in the interest of time, and I want to emphasize that we're getting very exciting, that there might be a very common denominator here which induces all those cytokines. And I just want to end up with a nice picture of a fungus here and 4 eosinophils. 1, 2, 3, and the 4th one who's trying to eat up the fungus here as well. This is the only visible portion. Thank you so much for your attention.
Thank you very much, Professor Bonicau. Now, if any question for Dr. Bonicau and Dr. Verkau, please come here.
Yes. Dr. Bonicau, a most interesting, fascinating lecture.
Sorry, who's speaking?
I'm Dr. Nagar.
Yeah, I'm Hamad.
Okay.
Yeah.
I just have a question. How far, sir, have you been successful up to this date in convincing the world of rhinology research of your theory of the fungal origin? So if we have 1,000 rhinology researchers all over the world, how many are convinced now of your theory? And the second question I want to ask you, because I know you are a real scientist, what is the strongest evidence against your theory?
Okay, very good. Excellent questions. Of course, there are a lot of doubters out there, but the doubters are not anymore among the rhinologists. What I've shown you here is data, and there is an army of immunologists jumping on this, because for the very first time, we actually have a trigger to induce the inflammation in that fashion. And all of that wouldn't have been possible without having a trigger for it. So now we can actually create it, and then we can test what blocks it. And I showed you the last slides were an example of that. So for us, this is getting very, very exciting. I completely agree with you. It's bypassing, in a way, the field of otolaryngology. Because they're not immunologists. They don't understand the potential significance of the data. But this is actually what we're basing drug discoveries on. What is a trigger for that inflammation? And I understand that there is some doubters and some questions, and partially it has become because we couldn't confirm the initial trial results with antifungal medication. One of the examples I've shown you why the treatment went essentially south and didn't work. I can only emphasize that we did a similar pathway with anti-IL-5 early on, where the initial trials haven't worked for it to improve the asthmatic symptoms, and then we started to understand what we're doing wrong in the trials. Or maybe that we need to target the population differently, the ones who produce a huge amount of IL-5. So indeed, there is a lot of doubters here. My initial, what I wanted to do is give you an outlook where we're going down with this. What is the most cutting-edge research? These are all things discovered in the last 2 or 3 years. And it's done, again, by an army of immunologists, not even myself anymore. And it's bypassing the ENT field. And my intention was to give you a little taste of the update of what's coming down the pathway. What are we using as a discovery platform? How can we actually discover new drugs? Now that we have, for the first time, a trigger which turns everything on. This is, for me, the exciting part. And this is not whether I can convince an ENT, which I remain very, very skeptical. But we continue to go down and say, show me another trigger which turns every part of the immune system on in that fashion, including the initiation of the innate immune system. That, for us, is one of the most exciting things, to go down a little bit to the origin of disease. We're unable to do that in humans, unfortunately. Yes, please.
Yes. I'll have one small question for Dr. Bonica, please. Before, when we speak with a patient, let us to speak some clinically, and the patient have chronic sinusitis with the polyps, and we explain to the patient, if he needs surgery, we will do surgery, but we cannot give guarantee. There is no recurrence for the polyps. The polyps will come back. When? Nobody knows. It depends on many factors, and we explain the patient that. Mm-hmm. But in the cases of the chronic rhinosinusitis, you change, and your colleagues, something about the pathophysiology of the chronic rhinosinusitis. Mm-hmm. Before we speak about there is closure of the natural ostium of the sinus, and there is sequencing of that leading to chronic sinusitis. Now we change it. The eosinophil travel to the nasal mucosa, to the mucus degranulation, major basic protein will come out, and all reaction of the whether chronic rhinosinusitis, whether bacterial or the fungal. Mm-hmm. In this condition, if the patient comes with chronic rhinosinusitis and ask like the other patient of the polyposis, okay, you will treat now chronic sinusitis surgically, endoscopically. Any guarantee from you, this chronic sinusitis, it will not come back? Shall we explain to the patient, no, or we start to say it is immunologic disease and it will come back and so, like the polyposis? What you can say?
Yeah, one of the ways we explain that, and this is not a guarantee, is keep in mind that what we do with surgery is we remove a lot of the mucus. And one of the things we actually learned by doing this research is if you leave some of that mucus behind, then the recurrence is occurring much, much quicker. So we learned really it's not so important to remove all the tissue. We actually put an irrigation in there during surgery. We thought we were all done and everything looked clean, and then we're always surprised how much additional mucus comes out when we, at the end of the surgery, irrigate everything out. So this...
mucus membrane?
Yes, absolutely. If you leave that mucus behind, forget about the fungi for now.
Yeah.
What is also in there is the toxic products from the eosinophils. That mucus is toxic. It must be removed during surgery. And if you leave that behind, and the only way we get it out is to put actually a relatively forceful irrigation into the sinuses with a catheter, with a syringe, and nicely irrigate everything out. And we're surprised. We think we're done and everything is clean, and out of any kind of corner suddenly comes huge chunks of mucus again with the same findings in there. The second point is what we really learned is that there needs to be some kind of what we call a stasis-causing event. Normally, I've showed you when the epithelium works nicely, it transports everything away. And you do sinus surgery, and the patients are doing fine normally after the surgery. However, when is it when they recur? Normally, they come to our office and say, I was doing great for a year, maybe even 2 years.
Exactly.
But then I had this viral infection, a common cold, and then suddenly after that, all my sinus trouble occurred again. Keep one thing in mind. A normal spore you put back there when you inhale, it gets transported away within 20 minutes. A normal germination, when the fungus actually produces the antigens which are recognized by the immune system, is actually occurring after at least 2 hours in a perfect environment there. In other ways, only if you have a stasis there, the fungus can accumulate and the antigen can accumulate, and the immune system starts to react again. Again, this is no proof for that. That's how we think it explains what we see so well clinically. Namely, thus the surgery initially works pretty well, but depends on whenever the patient has those quote-unquote stasis-causing events again, they will recur. And they can recur quite rapidly.
Thank you.
Yeah.
Excuse me. Yeah.
Yes.
You.
I'm from Egypt, and it's very important right now to explain why fungal immunotherapy is not producing good result except for alternaria.
Yeah.
right now I understand why. This is very important. Also, alternaria is not always isolated hypersensitivity or allergy.
Correct.
Associated with other multi-allergens.
Yeah.
So, right now the patient will respond very well because of the association with alternaria, and if we treat alternaria, this will be reflected on the other allergen also. The
Well-
cell, yes.
Yes, not so fast, because what we see clearly are two things. Number one, believe it or not, we're getting down to not just alternaria, it's actually one protein coming out of the fungus which appears to inducing this. So it's not actually sometimes alternaria, depends on the growth cycle of the fungus where it's in. We actually have to buy different lots and test them before we can actually do the research on it. So alternaria is not equal alternaria. The fungus is always there. We sometimes cannot isolate it, we sometimes cannot grow it, but we can measure that specific protein coming from alternaria all the time in this
Okay,
association.
and
Yes,
what's
please.
the difference if we have sensitization and not infection? This is not necessarily to be inside the nasal cavity or in the upper respiratory
Yeah.
tract. And now you say that the exciting factor is starting from the presence of alternaria, or this is the good model you explained it to us.
Yeah.
So you recommended to use the antifungal therapy, chemotherapy, to reduce sensitization even in not associated with the heavy spores or even hyphae or fungal of alternaria inside the nasal mucosa?
Sure. No, right now, because even our own trials using certain antifungal approaches have failed in the initial phase 3. So I'm shying away a little bit of trying to recommend this. And I make this clear. We're still using it, but we still use a different formulation where we actually put it in still water so it gets better absorbed into the mucus. And we explain it that it gets better delivered that way. I'm also trying to emphasize that this is not necessarily an IgE-mediated reaction we're talking about. This is clearly a non-IgE-mediated, and some people, in addition, develop IgE. But it was fascinating. Quite honestly, I never thought in my wildest dreams that this is necessary to potentially initiate an IgE-mediated allergy. I never thought that far about it. That was kind of a side effect from the initial research here I showed you today. So we don't claim we're done yet. I'm just trying to say that for the first time we have a trigger which turns all the players on, and we're starting to discover new players in this whole reaction. And without that, we cannot probe into the mechanism of how this all happens. Without a trigger, we have nothing. And we cannot test new medications or new blockages that way. So for us, it has become what we call a discovery platform, because for the first time we can initiate the disease in that fashion, in an experimental setting.
Okay,
That's the excitement about it.
Okay, okay.
Sorry, this Dr. Jurasley is one of the fellow of Royal College of Surgeons. It's a comment and a question, to be honest. It's a fascinating talk. We learned very, very important concept that epithelial-derived interleukins are starting playing part in our field. That's something new. We have the interleukin 25 as well, which has other rules to work, and we have already discovered 2 interleukins. There should be some more.
Correct.
Now, it's an imbalance. Yeah? The viral infection, the bacteria, which trigger extensive return of the polyps, taught us that our problem is imbalance between Th1 and Th2. We were heightening Th1 from our study. Now, it is very apparent, and when you said, talked about IgG started playing part, so we can't separate. It's just the imbalance which shift things to autoimmune disease or to allergic disease. But it's not totally innocent Th1, and this is quite clear from our things. Now, my question here, is it just a protein which is triggering such kind of epithelial type of interleukins or other interleukins? Do we have other substances, pollution, for example, which have different, and is it adhesive protein in reality, which is starting all that processes, and it is merely genetic based, and can we find it?
Yeah. We're asking ourselves similar questions. And it's actually not a protein, but it's also a protease, which is doing all this. So it's actually a fascinating substance we're hunting down. But again, without the trigger, we could not find it. We cannot isolate it. We cannot test it if it does those things. So we're going down to actually think it's a unique opportunity we have to probe into those mechanisms. We cannot exclude that there are other triggers. Of course not. But it's the first time we have one which turns all the players on, and we're discovering new players. Would I have ever imagined that there is an innate immune system initially involved in this? By no means. They discovered this, and I was like fascinated by the fact what else the fungus turns on initially. As I said in the beginning, would I ever thought that we can go back to the origin of disease to say what happens? Probably not in a patient, because they have it by the time we see them for a while. But we can use those platforms, which we are now allowed to develop with this, to get a little bit of a conclusion what's going on in the patients. And only then we can actually come back and develop new treatment pathways that way. And I'm also trying to initiate, to say, hey, remember IL-5, IL-13, everything which gets turned on, that's steroids work already. So if this is an emphasis again, that actually they're doing a pretty good way already of going down this pathway. And there are new treatments coming, specifically targeted for patients who have high IL-5, specifically targeted for patients who have a high IL-13, or even IgE has shown some efficacy in nasal polyps, specifically when they had an IgE-mediated allergy there. But the most promising right now is, and they're all in phase 3 clinical trials right now. So this is not based on the fungus. We knew that before. We just never understood what is actually inducing the production of those cytokines. And that was something where the new avenue takes place. And without the induction, we cannot make any further research in that.
Dr. Monica, please, I have one question, small question. Dr. Hussam Busrati speak to you about today about the allergy and the turbinate surgery. I have one patient, actually, I didn't believe on that. I heard from Dr. Ala Sulaiman, and he learned me to do it, but I didn't convince. Anyhow, I have one patient with bronchial asthma and severe allergic rhinitis. I treat him more than 1 year, and always come with his family, no improvement at all. So I did submucosal ablation with radiofrequency. This patient, he came once after 1 month, completely different. I didn't like to say he improved 90%, no more complaint. He came with his brothers or daughter, one of his family, 6 months before for his brother. But for himself, he said to me, I am very nice, no more complaint about the allergic rhinitis, no more complaint about the bronchial asthma. So what is the mechanism of this submucosal ablation of the inferior turbinate on the severe cases of the allergic rhinitis and asthma? Is this to decrease the vascularity? Is this decrease the surface area of the mucous membrane of the turbinate, or you have something else about that?
Well, I definitely think that if you, what we learned is that at the end of the day, it starts feeding the same pathway. If you have a patient which is also allergic, certainly has a secondary mechanism through the mast cell degranulation, through B cells producing IL-4, through the mast cells producing IL-4, to attract even more eosinophils to it. So for us, I always looked at it as a comorbid disease 5 or 10 years ago to say, well, some patients have allergies, some not. The eosinophilic airway disease, whether it's asthma or polyps or other chronic sinusitis, happens with or without detectable allergy. But it can certainly fuel the fire and make patients worse. Now, with this data coming out, I'm starting to go back and saying, maybe there's more of a connection between eosinophilia and allergy, that allergy is one of the legs which is also initiated by the same trigger. At least that's what the initial data seems to suggest. Why in some patients they don't and some other patients do? Is it a certain genetic predisposition in that regard? Is it an exposure level in that regard? Obviously, we don't know yet.
How about the improvement of the bronchial asthma after improvement of the allergic rhinitis in this case?
No, very difficult to answer that in a scientific way. Some things happen by coincidence. Yeah? Maybe the patient had some changes despite of the surgery, maybe removed an allergen, maybe removed the cat or the dog or something like that. But I can only say at present there is no good evidence. Is it not working? Oh, I can turn it on. Is it on now?
Okay, take this one.
Now yeah. Sorry, you can take that again. Sorry. At present, there is not much evidence to suggest that surgery plays a role in the treatment of allergic rhinitis. And I would say unless we have a study to confirm the results from this incidental finding, I would be reluctant to suggest surgery for allergic rhinitis. Nevertheless,
Submucosal ablation for
okay,
the
but ablation,
like cauterization or
yeah,
whatever.
but radiofrequency is removal of epithelium. Yeah, now I know what you mean. It's not surgery, but it is mechanical or thermal removal of epithelium. I don't think there is any data for that, and I would say congratulations that it worked in your patient so wonderfully, but I wouldn't be able to explain the mechanism behind it. With all due respect to Professor Ponikau's wonderful research there, I think one explanation remains open is why does not everybody get nasal sinusitis, chronic sinusitis? Because everybody inhales fungal spores, and very few patients, luckily, get this very dreadful disease. And the other question, of course, is why do mice in nature who have their nose in alternaria all the time do not have chronic sinusitis by nature?
Thank you very much. We will go now for the break.
Excuse me,
10 minutes only.
Can I have a question, please? You know,
Okay.
you mentioned...
You comment.
Sorry.
Yeah. First of all, the mice you've shown here, they are raised under sterile conditions. They are certainly breathing filtered air, and they are not being exposed to alternaria before. This is why we couldn't understand why they're not sensitized in that way, because they were not sensitized to them, and that is something which made our head scratch, and this is how they discovered the ILC2 pathway for the innate immune system. And the second one is that certainly we see, as with every chronic disease, we believe it's still a matter of a certain genetic predisposition and an exposure level. That means you can have a certain level of, and how many times do you have, quote-unquote, a stasis in there. We also see, of course, once your immune system is kept busy with the fighting off infections and shifting towards the Th1, maybe there's no room to shift to a Th2 kind of process here. So we understand that certain bacterial infections were actually helpful in avoiding the development of hyperreactive airway disease. In other words, when people or kids were having more bacterial infections or acute infections in the childhood, they were obviously not developing so much of a Th2 pathway.
Thank you very much.
That's how we explain it again.
Thank you. Thank you very much, and thank you, Professor Virchow. And now still less than 10 minutes for the coffee break. Okay? And after that, we'll come back. Thank you very much.